Hello, my name is Maria Moreira, and I'm an emergency medicine physician at Denver Health. This presentation will provide a review of the care for the pregnant patient in a disaster setting. I have no financial disclosures that affect the content of this talk. This topic is important because 20% or 1 in 5 women of childbearing age are pregnant in a disaster setting. Additionally, studies have suggested an association between disaster and poor pregnancy outcomes. Some of those poor outcomes can include early pregnancy loss, birth defects, low birth weight, preterm birth, and placental abruption. Maternal and child mortality is 10 to 30% higher in disaster settings than non-disaster settings. So, being prepared to be able to take care of these patients can make an impact. In this module, we will review the physiologic changes in pregnancy, as understanding the normal changes in pregnancy will allow us to better identify the abnormal. We will discuss pearls and pitfalls in treatment of pregnant trauma patients. We will describe techniques for difficult deliveries to be prepared for the unexpected. And additionally, we will discuss presentation and management of some OB emergencies that can still arise in the normal progression of pregnancy, even in a disaster setting. In pregnancy, the uterus begins to expand. At 12 weeks, the uterus and bladder come out of the pelvis, thus making them both more susceptible to trauma. At 20 weeks, the uterus is at the umbilicus. And in a normal growing pregnancy, the size of the uterus in centimeters roughly correlates with weeks of gestation. Pregnancy hormones create a high volume, low resistance state. The primary event is peripheral vasodilation, which leads to a decrease in systemic vascular resistance. Additionally, there's an increase in plasma and red blood cell volume. However, the increase in plasma volume is greater than the increase in red blood cell volume, thus leading to a physiologic anemia of pregnancy. In order to support this increased volume, cardiac muscle mass and contractility also increase. These changes lead to an increase in cardiac output, which early on is mostly due to an increase in stroke volume, but is also supported by a slight increase in heart rate. And in pregnancy, heart rate will increase about 10 to 15 beats per minute. So in pregnancy, vasodilation leads to a decreased systemic vascular resistance, and there's a concomitant increase in blood volume. Cardiac contractility, stroke volume, heart rate, and cardiac output all increase. Cardiac output increases 30 to 50%. Due to the vasodilation seen in pregnancy, blood pressure will decrease. Diastolic blood pressure can decrease about 10 points. The decrease in systolic blood pressure is usually only a 2 to 3 point decrease. The main thing to remember here is that if a pregnant patient has a blood pressure higher than their pre-pregnancy blood pressure, that is abnormal because we would expect a decrease in blood pressure in pregnancy. Progesterone works on the respiratory center to increase the depth of breathing. Thus, pregnant patients have an increased tidal volume. This leads to increased minute ventilation, and in pregnancy, normal PCO2 is 27 to 32 millimeters of mercury. As the uterus expands, the diaphragm is going to be pushed up and can be pushed up as much as 4 centimeters. This pushing up the diaphragm and the increase in tidal volume will both lead to a decrease in functional residual capacity. So in pregnancy, oxygen consumption increases 15 to 20%, yet pregnant patients have decreased reserves. The high volume state of pregnancy also leads to an increased glomerular filtration rate and a decreased creatinine. And in the GI tract, progesterone levels lead to smooth muscle relaxation, leading to decreased gastric emptying and decreased esophageal sphincter tone that can make this patient susceptible to reflux and aspiration. When pregnant patients are affected by trauma, maternal circulation will be maintained at the expense of the fetus. Tachycardia is a late sign, so we should not be falsely reassured by the patient's vital signs. Pregnant patients can lose a lot of blood before showing you any change in their vital signs. We also need to avoid supine hypotension syndrome. After 20 weeks gestation, when pregnant patients are in a supine position, the uterus can constrict the vena cava, thus decreasing venous return and leading to a 25 to 30% decrease in cardiac output. This can translate to a 30-point drop in systolic blood pressure. Thus, pregnant patients at 20 weeks gestation and above should be placed in a left lateral decubitus position or have the uterus manually displaced off of the vena cava. If the patient is on a board, the board can be tilted about 15 degrees, placing sheets under the right side of the board. The uterus can be manually displaced in the following manner. If on the right side of the patient, push the uterus from the patient's right side to the left. If standing on the left side of the patient, pull the uterus towards you. Fetal heart tones are an important vital sign in pregnancy. Fetal heart tones may be the first sign of distress. They can be assessed by the use of ultrasound, and they can also be assessed at 20 weeks gestation and above by stethoscope. Normal fetal heart tones are 110 to 160 beats per minute. In these patients, because the peritoneum has been slowly expanding and can be somewhat desensitized, intra-abdominal hemorrhage can be present without peritoneal signs. These patients require aggressive fluid resuscitation given the high volume state. Additionally, we need to consider fetal-maternal hemorrhage and RH sensitization. We need to administer RhoGAM to patients that are Rh negative to prevent problems with future pregnancies. This should be given within 72 hours of trauma. Remember that these patients have an increased oxygen demand but decreased reserve. Aggressive airway management should be provided, and patient saturations need to be maintained above 95% to assure good oxygenation of the fetus. Due to displacement of the diaphragm upward as the uterus expands, in patients requiring chest tubes, the placement needs to be altered by going 2 interspaces higher than normal. In general, when approaching a pregnant trauma patient, we can divide the presentations into different categories. If the mother is stable and the fetus is stable, which is the best possible scenario, we still need to watch these patients and toco monitor them for a minimum of 4 hours. Toco monitoring allows assessment for placental abruption from trauma, which is where the placenta is detached either partially or completely from the uterus. Studies have shown that of the patients with 8 or more contractions per hour during the monitoring period, 100% of those patients had placental abruption, and those patients need to be delivered. If patients had less than 6 contractions per hour, they have not been shown to have a placental abruption and they can be discharged. Those with 6 or 7 contractions per hour need to be observed further to determine if delivery is required. If the mother is stable but the fetus is unstable and the fetus is viable, an emergency C-section can be performed. If the mother is unstable, we need to identify and treat the mother's injuries, as that is the way to obtain best maternal and fetal outcomes. If the mother goes into cardiac arrest, we should consider a resuscitative hysterotomy if the pregnancy is at or greater than 24 weeks gestation. At 24 weeks gestation, we may be able to both resuscitate the mother and the fetus because the fetus at 24 weeks is viable. The procedure should be started within 4 minutes of arrest, with best outcomes when the fetus is delivered within 5 minutes of pulses lost. Removing the metabolic demand created by the fetus and the impact from pressure on the vena cava may lead to better resuscitation of the mother. In the circumstance when gestational age is not known, if the uterus is at the umbilicus, the patient is at least 20 weeks gravid. At this point, a resuscitative hysterotomy can still be performed in an attempt to resuscitate the mother. In a disaster, the mother will always be prioritized over the fetus. Trauma can induce labor, or patients can be in labor and be involved in a trauma. We need to be prepared to deliver these patients if they cannot be transported to an OB or other physicians specializing in deliveries. In a normal vaginal delivery, when the head is crowning, the provider supports the head and the perineum. We want to avoid a precipitous delivery or perineal tears. Once the head is delivered, the baby's head will look to one side. We'll check for a nuchal cord. Once we assure ourselves that a nuchal cord is not present or we reduce the nuchal cord, then we can place one hand on either side of the baby's head and provide gentle guidance downward to deliver the anterior shoulder and then gentle guidance upward to deliver the posterior shoulder. Once the baby is delivered, we're going to wait 30 to 60 seconds to clamp the cord per ACOG recommendations. The World Health Organization recommends 1 to 3 minutes for delayed cord clamping. Delayed cord clamping is beneficial as it increases iron stores at 6 months in full-term births. It also has the added benefit in preemies of a lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. When a nuchal cord is present, there are several options for delivery. One is to first reduce the cord over the head by using gentle traction on the cord. The cord can also be pushed towards the perineum and over the baby's shoulder and the baby delivered through the cord. Another way to deliver a baby that has a nuchal cord is by the use of the somersault maneuver. In this maneuver, you place one hand supporting the baby's head and the other pushing on the baby's occiput, delivering the baby laterally towards the mother's leg. During this time, we maintain the baby's head and the baby's neck very close to the perineum to prevent stretching on that cord. Once the baby's delivered, we can flip them or do the somersault to reduce that nuchal cord, or we can simply reduce the nuchal cord over the head. The last maneuver of clamping and cutting the cord really should be avoided, because if we clamped the cord and then we have difficulty delivering the baby, we have just stopped the blood supply to the baby. So we should not clamp and cut the cord until the baby is delivered. Shoulder dystocia should be considered in the situation when the baby's head is delivered, and with each contraction, the baby's head moves forward but retracts towards the perineum once the contraction is over. This is called turtling. There are various techniques that can be used, and each has varying success in different studies. The least invasive technique is the McRoberts technique, in which the mother's legs are hyperflexed. With this technique, we also provide suprapubic pressure. The suprapubic pressure is provided right over the symphysis pubis, and it's a downward and lateral pressure towards the side that the baby's facing. Because what we're trying to do is we're trying to externally push the baby's shoulder towards their chest to try to decrease the diameter between the shoulders. If this doesn't work, you can move on to internal maneuvers. In the Rubin maneuver, you place two fingers on the posterior aspect of the anterior shoulder of the baby, and you push the baby's shoulder towards their chest. Again, here, the hope is to decrease the diameter between the shoulders in hopes that that anterior shoulder will now come out from under the symphysis pubis and deliver. If that doesn't work, keep the two fingers that are posterior to the anterior shoulder in place, and now place two fingers of the other hand anterior to the posterior shoulder of the baby, and start rotating the baby 180 degrees. That's the Woods corkscrew maneuver. If that doesn't work, you can move your hands and rotate the baby back 180 degrees the other way. With this maneuver, the baby's shoulder might dislodge from behind the pelvis when it is in a greater diameter in the pelvis. The last maneuver to discuss is the posterior arm delivery. In this maneuver, you push up the posterior arm to sweep it up across the baby's chest. Then you grasp the baby's hand once you see it, and you pull it along the side of the face and deliver the posterior arm. Once the posterior arm is delivered, the rest of the baby's going to fall in that pelvis, and the rest of the baby should be delivered easily. Obstetricians tend to prefer this maneuver after trying hyperflexion and suprapubic pressure. The patient can also be asked to get on all fours, and all of these maneuvers can also be done in that position. One thing that we need to remember is that we need to note when that head is delivered, and we need to keep track of timing, as best outcomes are when the rest of the baby's delivered within 5 minutes of the head being delivered. So we typically try each maneuver about 30 seconds and then move on to the next maneuver if it's not successful. If a mom is in active labor and the presenting part is the buttocks, we will need to deliver the breech baby vaginally. We allow the mom to push until the baby's out to the level of the umbilicus. Then we can start to help in the delivery. We exert pressure on the back of the knee and we guide the thigh away from the trunk, and we deliver each leg in that manner. Then we let the mom push until the scapulas are seen, and then we will rotate the baby and sweep the arm across the baby's chest. We deliver each arm. Once each arm is delivered, now you place the baby's body on your dominant hand. You place an index and middle finger of the dominant hand on the fetal maxilla, support the neck with the other hand, apply pressure on the maxilla to maintain head inflection, and you elevate the fetal body from the horizontal plane to deliver the head. Another person can provide suprapubic pressure when you're trying to deliver the head to also help in that flexion. If the head is stuck, you may need to give nitroglycerin or terbutaline to relax the uterus to help deliver the head. Cord prolapse needs to be delivered by C-section. The problem with the cord presentation is that with contraction, the baby's presenting parts can compress the cord. Additionally, if the cord gets cold, it can spasm. Both compression and spasm can lead to fetal hypoxia, bradycardia, and ultimately fetal death or permanent disability. In this situation, we apply a moist sterile dressing to the cord and we elevate the presenting part and assure ourselves that we can feel pulsations in the cord. We're going to elevate that presenting part by placing your hand between the presenting part and the cord and pushing that baby's presenting part up off of the cord. Other maneuvers that can help move the presenting part away from the cord include placing the patient in the Trendelenburg position, which is a head down position, in the knee chest position as seen in the picture here, or in the exaggerated Sims position, which is the patient on their left side with the hip elevated. In these positions, gravity is helping to move the baby's presenting part off of the cord. Additionally, we can retrofill the bladder with 500 to 700 cc's of saline to help move the baby off the cord. The thought is that as the bladder is being filled, it is going to start pushing that baby part up and off the cord. Tocolytics may need to be administered to keep the mother from pushing. With any delivery, we need to be prepared to treat postpartum hemorrhage. While the definition of postpartum hemorrhage has varied over time, most definitions include a blood loss of either 500 or 1,000 mLs with signs and symptoms of hypovolemia. We need to remember the 4 T's of postpartum hemorrhage: tone, trauma, tissue, thrombin. These are the causes of postpartum hemorrhage. Atony is responsible for 75% of cases of postpartum hemorrhage. We will administer oxytocin to the patient. Now, oxytocin can be administered after delivery in all pregnancies, and oxytocin, when given, the number needed to treat to prevent 1 incidence of postpartum hemorrhage is 7. If we haven't given oxytocin, or we've given it, but now the patient has been noted to be in postpartum hemorrhage, we can give a dose of oxytocin again, and typically we'll give them 10 to 20 units intramuscularly. We can consider using other uterotonics if the oxytocin isn't working. We can use Hemabate, Methergin, or misoprostol. We also will administer a gram of TXA, and that's secondary to the women's study, which showed a 19% reduction in mortality from bleeding. It is also important to empty the patient's bladder because a full bladder can prevent the uterus from contracting. And we'll also provide fundal massage. If those maneuvers don't work, we're going to move on to bimanual massage. That's done by placing one hand in the vagina and pushing against the body of the uterus, while the other hand compresses the fundus from above through the abdominal wall. If that doesn't work, we can move on to tamponade by placing an intrauterine balloon. We can use a Bakri balloon, but we can also use other type of balloons if we don't have a Bakri, such as multiple Foley's or a gastric balloon of the Blakemore or Minnesota tube. We can also just simply pack the uterus. Blood products will be administered to continue the resuscitation of the patient, and the patient eventually will probably need to go to OR or IR to control the bleeding. Trauma is the second most common cause, making up about 20% of causes for postpartum hemorrhage. We want to do a thorough well-lit exam, and what we're looking for are lacerations, and we repair them if we see them. And we also are looking for an inverted uterus, and we'll reduce the inverted uterus if one is present. For these patients, we're going to continue the resuscitation and correct their hypotension. If tissue is the cause of the postpartum hemorrhage, and this is retained placental products, we're going to do a manual assessment and remove the products manually. And we're going to continue to correct hypotension through resuscitation with blood products. If, as we're doing our manual assessment, that placenta is very adherent, it might be that we have a placenta accreta, and those patients are going to need to go to surgery to remove that placenta. If the patient has a coagulopathy that is the cause of their postpartum hemorrhage, we're going to continue the resuscitation and we're going to prevent hypothermia, as hypothermia will make coagulopathy worse. We're going to consider intrauterine balloon catheter to help tamponade the bleeding, and we monitor coagulopathy with labs. This patient might also need operative management in IR or in the OR to control bleeding. Pregnant patients in a disaster setting will still present with emergencies seen during non-disaster periods. One of the emergencies we need to be prepared to manage is peripartum cardiomyopathy. The definition of peripartum cardiomyopathy is heart failure in the last month of pregnancy or within 5 months after delivery with absence of another cause of heart failure and presence of left systolic dysfunction. All 3 of these criteria must be present. Symptoms that are seen are symptoms normally seen in heart failure, such as dyspnea, cough, orthopnea, paroxysmal nocturnal dyspnea, pedal edema, hemoptysis, fatigue, and lightheadedness. Exam findings include elevated jugular venous pressure, displaced apical impulse, third heart sound, and mitral regurgitation murmur, a holosystolic murmur best heard at the apex. The goal of therapy is the same as in other patients with heart failure and reduced ejection fraction. However, we must consider fetal and neonatal risks of medications and treatments. Our goal is symptom relief, decreasing pulmonary congestion, and optimizing preload and afterload. We're going to provide the patient supplemental oxygen and assisted ventilation if needed. We want to optimize preload through diuresis. Loop diuretics are preferred, and we can add thiazide diuretics such as hydrochlorothiazide if volume is not controlled. We want to balance the patient's intra and extravascular volume, and we want to really fluid restrict them. If vasodilators are tolerated for afterload reduction, hydralazine plus isosorbide dinitrate is the preferred regimen. Patients that are in decompensated heart failure, who are hypotensive or remain in pulmonary edema despite oxygen therapy, diuresis, and vasodilators, may benefit from inotropes and vasopressors. Dobutamine and milrinone have both inotropic and vasodilatory effects and may be beneficial in pregnancy. Norepinephrine is also safe in pregnancy. Once we stabilize the patient, then we can initiate chronic therapies, which will include diuretics, beta blockers, and potentially other drugs such as digoxin. However, ACE inhibitors should not be used. Timing of delivery will depend on status of the mother and the maturity of the fetus. If the patient is unstable, regardless of medical therapy, delivery may be required. The last two emergencies I want to talk about are preeclampsia and eclampsia. Preeclampsia is defined as systolic blood pressure greater than 140 or diastolic blood pressure greater than 90, plus the onset of at least one of the following: blurred vision, scotomata, flashing lights, as far as visual changes, pulmonary edema, proteinuria, serum creatinine increase, liver transaminase elevation, new onset or persistent headache that's not responding to analgesics and not explained by another diagnosis, or decreased platelet count. Eclampsia is preeclampsia plus seizure or coma. For preeclampsia, we're going to treat the patients with antihypertensives. Typically, the patients that we are going to provide antihypertensives to include those that have a systolic blood pressure of greater than 160 or diastolic blood pressure of greater than 110, or if it will be weeks before the delivery in a patient with preeclampsia without severe signs or without blood pressures that are in the 160 systolic or 110 diastolic range, or if the patient has chronic hypertension. The hypertensives used are typically labetalol, nifedipine, or hydralazine. Magnesium is administered in severe preeclampsia to prevent seizures. Corticosteroids are given to promote development of the baby's lungs before delivery and should be given if gestation is less than 34 weeks. Delivery is the cure and should be timed appropriately. If the patient is 37 weeks or above, they should be delivered. Those that are above 34 weeks with severe features should be delivered. For patients between 24 and 34 weeks, if we can watch them closely, we can do expectant management and have time to give antenatal steroids. For patients that have eclampsia, delivery is the treatment. In the meantime, we will place the patients in the left lateral recumbent position. We're going to minimize stimulation, provide oxygen, and get an IV. We're going to manage the seizures with magnesium or benzodiazepines. Magnesium is preferred, and we typically load the patients with 4 or 6 grams of magnesium and then follow that with a drip. If the patient has renal insufficiency, we should lower the dose of the drip. These patients, again, need to be delivered. That is the management. If before delivery they're having persistent seizures or seizures that aren't managed with magnesium, we can also provide benzodiazepines to help with that management. In summary, for pregnant patients in a disaster setting, we want to consider the physiologic changes of pregnancy. We want to apply a few pearls to improve the care of both the mother and the fetus, be ready for delivery, and be prepared for other pregnancy emergencies. Here is my bibliography with some resources, and this is my email. Please email me if you have any questions. Thank you for your attention.